Now let's start our presentations of today's webinar. Our first speaker is Professor Attilio di Spiezio Sardo. Professor Attilio di Spiezio Sardo is currently the chief of the Hysteroscopy unit at the Department of Obstetrics and Gynecology, University of Naples, Federico II, where he has performed more than 10,000 operative hysteroscopies, mostly in outpatient setting, applying the newest technical and methodological approaches. Since 2023, his scientific interest has been focusing mainly on the development and implementation of a new hysteroscopic technique. The high quality level of both research and the clinical projects developed by his team is testified by his intensive scientific production, as well as the many national and international meetings where he is personally invited as a speaker. So far, he has taught well over 150 national and international endoscopy courses and seminars, and he himself has actively organized several symposia and practical courses in his department and in other institutions. He will be giving the first presentation of today. Professor Spiezio, please.
So thank you very much for your kind presentation. I have to thank Professor Lee and Professor Long for being my chair today and for having invited me. And please let me also thank all the sponsors who made this event possible. You know that I'm very fond of the APAGE Society. I attended many meetings arranged in China, and I hope there will be better times in which we Europeans can come again to your wonderful country. Today we are speaking about the role of hysteroscopy for treating a pathology which is really very common, the retained product of conception. If you see these most recent data, it is a complication of nearly 1% of term pregnancy, but they are even more common after miscarriage or termination of pregnancy. And if you deal with hysteroscopic technique in your clinical activity, it will happen once that you will find a retained product of conception, and you have to know how to approach it. You know that it's still a challenging situation because the diagnosis is not very clear, because there are in the uterus of a lady after miscarriage or after a pregnancy, there are blood clots, so that the sonographic and clinical diagnosis is not very easy. And the problem is that we do not have established protocol, established guidelines that can guide us in the treatment of this condition. And what this data, it's very important that at the end, we think that we have retained product of conception, but when we send for pathological analysis, you see that in a large proportion of cases, histology does not confirm what you think it was inside the uterus of your lady. In the past, but I would say unfortunately still now, in many centers, DNC, which means blind dilatation and blind evacuation by means of a sharp curette, still represents the gold standard technique for the treatment of this condition. But apart that, every blind procedure has problems in terms of complication, in terms of no very effective way of removing the pathology from inside of the cavity. Keep in mind that we are speaking about a gravid uterus, and wherever trauma you are going to create inside the gravid uterus, this surgery is really very adhesiogenic. So if you use a sharp curette inside a uterus after a miscarriage, after a term pregnancy, and you create a trauma on this endometrium, it is very likely that this lady will develop important severe post-surgical adhesions. That's why, since 1989, some experience with the use of hysteroscopy combined with oriented curettage or alone hysteroscopy without any blind evacuation appear on international literature. So people understood that probably it would be better to remove this retained product of conception under direct vision of the uterine cavity. We will analyze which are the advantages of the hysteroscopic removal of this device. First of all, we have a direct view. Direct view is something which is very, important in hysteroscopy for whatever pathology you are trying to diagnose and treat. But mostly when you have malformated uterus or when you have retained product of conception located in a very unusual position, like in this case, that it was in the cornual area where it's very difficult with a blind technique to approach the retained product of conception. So the direct view is something that probably no one should renounce because you can see what is really and the position inside the cavity. Then what is important in hysteroscopy is that not only you can see where the retained product of conception is located, but you can also remove always under vision. And because we are in a tremendous pandemia, the COVID-19 pandemic situation, you know that in hysteroscopy, only during the phase of lockdown and even in phase 2, for example, in Italy, these are the hysteroscopic procedures that are allowed to perform emergency and procedures in which delay could potentially worsen the patient's outcome. And you see that among the emergency procedures, the evacuation of retained product of conception is one of the procedures that we were allowed to perform even during the lockdown that we had in Italy, you had in China, and go on. How to remove the retained product of conception? If you think that the retained product of conception is very friable, is a small specimen, please use, even for cost reason, the mechanical instruments. But if you see that this tissue is very adherent to the uterine wall, but is small in terms of size, you can use these 5 French bipolar electrodes, and so you can separate the retained product of conception from the wall. And of course, even in this case, you have to pay attention in order to avoid to create iatrogenic damage to the myometrium. You know that the standard technique, if you have to bring the patients to your operating room, is to use the resectoscope, but in a cold way. It means to use the loop as a curette under visual control. Or if you think that this device, this retained product of concept is abundant and tenaciously adherent to the uterine wall, you can also use an activated cutting loop. For example, on this video, you can see a wonderful 15 French resectoscope. So it means that you don't need to dilate the cervix, because when the device is 5 millimeter, it means that you can go inside the cavity without any cervical blind dilatation. You can resect the intracavitary portion of the retained product of conception, and then you can use the loop in a cold way, not activated, when you want to separate the base of the retained product of conception from the uterine wall. But you know that probably for the tissue removal device, retained product of conception represent one of the main indication. And you know that since the beginning, when we spoke about hysteroscopic removal of retained product of conception, many papers showed that the tissue removal device, and many of these devices appeared on the market, were very, very effective and safe in treating this pathology. And when we published the guidelines on JMIG regarding the hysteroscopic procedure during the COVID-19 pandemic, we have stated that despite hysteroscopy is not an aerosol generating procedures, but we don't have time now to explain why, but I invite you to read this article. However, in order to reduce this risk, which is, however, very, very low to generate bubbles coming in the atmosphere, it's better, mostly if you have suspected lady, to favor the instruments that do not produce surgical smoke. That's why in our institution, since February, when we have this tremendous pandemic, we are preferring the use of mechanical instruments, and of course, tissue removal device represent our main tool at the moment to remove all pathology and in particular retain product of conception. You see the advantages of having these devices. We have personally in our institution the 5mm tissue removal device developed by Medtronic, and we have the mini Bugatti shaver of 6.3mm. I think that these two devices have the main advantage that allow us to treat most of our pathology in ambulatory setting. The advantages that you see on the right slides, you see clear view, save time, low risk of perforation, low risk of adhesion, very easy. Our young trainee love this device. These are common for all the pathology that you want to remove. And particularly when you have retained product of conception, you can really save time, you can remove all the pathology, and without any use of electricity, you can do in a very safe and effective way without risk, and we will see later, to create damage to the healthy endometrium, to the healthy myometrium. And you see that we have said before that if you create damage to this kind of cavity, you probably will cause a more important and more severe problem, which is the post-surgical adhesions. And you know that recently my friend Shanazar Ansari from Iran has published her experience with Bugatti shaver, the big one, in order to remove the retained product of conception with many advantages. I follow the recommendation stated in her article that please don't try to remove as soon as you diagnose the retained product of conception, but wait a little bit more, because more you wait, less bleeding is observed. And because when you use the tissue removal device, you don't have the possibility to coagulate, it's much better if you do when the process is, however, burned down. So it means that no vascularization, the beta HCG is very low level, and so you don't have any problem of bleeding. You know that since the beginning, many papers have shown that the tissue removal device cutting and aspirating at the same moment represents a faster alternative than loop resection, and other great advantages, low rate of de novo intrauterine adhesion. The problem, many doctors ask me, but if it starts bleeding, how you can manage the bleeding that you have inside? Of course, what is important is that you follow this diagnostic sonographic algorithm. It's important that your sonographer can tell you if it's a type 0, type 1, 2, or 3 of the retained product of conception. And if the retained product of conception is highly vascularized, you think that it can bleed a lot during the procedure and you cannot wait that the process is burned down, please prefer devices in which you can use electricity in order to coagulate bleeding vessels. Then the last two advantages of using hysteroscopy for the removal of the retained product of conception. If you use whatever instruments are going to use, it seems that in comparison with blind curettage, you can have better pregnancy outcomes. But what is important is not only a higher pregnancy rate, but even the time to conception, that is a very important reproductive outcome, seems to be lower, shorter than using blind technique. Probably because you don't create adhesions inside the cavity, and even the time to reach a pregnancy is shorter. And of course, keep in mind, however, that wherever you have retained product of conception, even if you remove in a proper way by hysteroscopy, it's very important that these patients is counseled that in a future pregnancy, however, they can have a higher rate of abnormal placentation. So retained product of conception, even if it's perfectly treated, is a risk factor of abnormal placentation in a future pregnancy. Of course, what is important is that this lady and this paper confirm what I said before, that if you do bisection curettage, this risk is even higher in future pregnancy. So despite this lady have a higher risk of normal presentation, if you remove by hysteroscopy, however, this risk, despite it is a little bit higher than general population, however, it is lower than using blind curettage. And probably everything, better pregnancy outcome, better efficacy of the device is related to the fact that we create less intrauterine adhesion. I'm very happy that I've been invited in an APAGE meeting, because I know that the problem of adhesion is still an important problem in China, Japan, Taiwan. I read with very interest your tremendous series of Asherman syndrome coming from your country. So the problem of adhesion is very important, and please, probably in your region, the tissue removal device should be the first option, probably in terms of trying to reduce this risk of adhesions. And of course, if you reduce adhesion, you can have even better pregnancy outcome, as these two last paper confirmed. So just to conclude, the hysteroscopic removal of retained product of conception should become the gold standard. Among the different instruments that you can use, the tissue removal device, not only because we are in COVID-19 pandemic, should be the first therapeutic option for Our Lady. I read with great interest the results of the survey, and I hope that if I was clear enough, the knowledge of people towards this device will increase at the end of this webinar. And once more, I thank you. I thank all of you for giving me the permission to have this talk. Thank you very much.
Thank you, Professor Spiezio, for the sharing. Now let's see the questions we have from the audiences. Yes, here in the right side of the chat box, Professor Spiezio, and some audiences suggest the question: do you suggest this in the immediate post-abortion period, or only for chronically returns POC? When it is returned for more than 15 or 30 days post-abortion, something called placenta polyps. Yes?
Very, very good and pertinent question. What I recommend, that if there is only the sonographic suspicious of retained product of conception, but not of clinical indication, which means no severe bleeding, no complaint on the part of the patients, please don't do, because we have said before, if you can wait a little bit more, the retained product is less vascularized, less problem. Most of the time, you don't need even to do surgery, because, I mean, it comes out with the location of the patient. I recommend to check with ultrasonography after 1-2 months, because otherwise, in the first day after the termination of pregnancy or after the miscarriage, you have always the sensation that there is something inside the cavity, and if you put the color blood flow on the subendometrial space, you have always the sensation that there is arterovenosus malformation or something going wrong in the myometrium of the lady. Please, the clinic is very important in this case, more than the sonographic appearance.
Okay, thank you, Professor Spiezio. Yes, you just mentioned the accurate diagnosis before hysteroscopy procedure is quite important in dealing with the return of pregnancy products. So the next question: how long the maximum time for procedure of retrieving returned placenta due to overload fluid? Do you have some suggestions?
Yeah, there is no maximum time for any procedure inside the uterus. Polypectomy, myomectomy, retain product. What is important is to check the fluid balance. More you are working inside the cavity, less you have to be worried about the problem of overload fluid. Wherever you are going inside the myometrium, but when you do myomectomy, or even if you are going to resect the base of the retained product of conception, if it is very adherent to the uterine wall, please check the fluid balance. And if you use saline, you have to follow the AGL European Society guidelines published together, I think even in conjunction with the APAGE Society, which means 2 liters should be the maximum of a difference between inflow and outflow when you should stop surgery.
Oh, great. So now let's move to another question here. What's the lure of hysteroscopic procedure for morbid adhesion of placenta or increta here?
In this kind of situation, what is important is that we, in our institution, we prefer to leave the placenta inside to check blood coagulation of the lady, to do a coverage with antibiotics, and we do a protocol with methotrexate in multiple injection. And only when the process has been burned down, which means that the beta HCG comes to 0 or nearly 0, and the patient is not bleeding, you can arrange the removal by hysteroscopy. But keep in mind that if you have all the placenta inside, 6-7 centimeters inside, it is very challenging situation in hysteroscopy. You could have some problem. So you have to be patient and wait in this kind of situation.
Yes, before to do this decision making, I think some MRI scanning or imaging is necessary.
Very good, very good, very good. I forget to say, we always do as part of our protocol MRI to see in which area the placenta is adherent and how much is adherent, is infiltrating the myometrium. And according to that, we decide our injection of methotrexate.
Okay, for this session, the last question is, do you recommend cover with antibiotics before hysteroscopic modulation of a chronic returned product of conception?
Generally, when we do in outpatient setting, we don't prescribe any kind of antibiotics to our lady. When we put, but this is our institution, the lady under general anesthesia in the operating room, we only give an intravenous injection of antibiotics for all kind of vaginal surgery that we do just once time, and we don't prescribe any antibiotic after we discharge the lady.
Okay, thank you.